Welcome to the funnel effect. We are diving deep today into a topic that sits, well, right at the very frontier of cardiac intervention. The treatment of complex disease in the main hub of the heart's blood supply, the left main coronary artery, or LMCA.
This is definitely a deep dive with incredibly high stakes. I mean, the source material we're working with today, it gives such an essential and comprehensive look at the state of the art. It really synthesizes decades of clinical debate and, frankly, huge technological advancement.
Absolutely. And the foundation for this deep dive is that comprehensive contemporary review titled Contemporary State-of-the-Art PCI of Left Main Coronary Artery Disease, which was published in Circulation, Cardiovascular Interventions.
Yeah, really key paper.
We are drawing our insights directly from the work of Songbong Lee, Youngmin An, Duyun Kang, Songjung Park, and Duku Park. So credit where it's due to the authors.
Definitely. And our mission today really is to guide you through how the treatment for this critical condition has evolved. We'll be contrasting the traditional standard of coronary artery bypass grafting CBG with the stunning growth of percutaneous coronary intervention, PCI.
Right. And it's not just about what the guidelines say, is it?
Not at all. We need to understand why the data sometimes seems conflicting and, crucially, how all this new technology, this precision, is actually driving the decisions clinicians make today.
And we have to start with that high-stakes reality. For anyone perhaps newer to this field listening, the LMCA is, well, it's terrifyingly important.
It really is.
It supplies the two major branches, the LAD and the LCX, which means fundamentally it feeds over 70% of the entire heart muscle if that single pipe gets compromised.
The consequences are immediate and often catastrophic. The central hub, exactly. Obstructive disease right there carries significantly higher risks of, cardiovascular morbidity and mortality compared to non-LMCA coronary artery disease.
So the stakes, they just couldn't be higher for the patient.
No, they couldn't. And that's precisely why management decisions for this specific spot, this anatomical location, are subject to such intense debate and scrutiny.
Okay, let's put this into a bit more context then. How common is LMCA disease actually? And maybe more importantly, what were the odds for a patient historically, before we had these effective revascularization strategies?
Well, while it's incredibly severe, it's actually not overwhelmingly common. It affects approximately 5% to maybe 9% of all patients who have coronary artery disease.
So a relatively small slice, but a critical one.
Exactly. But the prognosis for that small group back before surgical or interventional techniques really became commonplace, it was frankly catastrophic.
Right.
The source material reminds us, and it's quite sobering, that if patients were managed only with medical therapy, which was the historical approach,
Right.
the 5-year cardiac mortality rates tragically exceeded 50%.
50%. Wow.
Yeah. It was effectively a death sentence for many people.
That context is just vital. It really underscores why, for decades, coronary artery bypass grafting, CABG, was so firmly established as the definitive, the gold standard choice for revascularization.
Absolutely. The sheer necessity of quickly restoring blood flow to that much heart muscle demanded the durability and the perceived reliability of surgery.
And CIBG is still an exceptional tool, we should say.
Oh, absolutely. It
Right.
remains a cornerstone. But what we've witnessed over the last, say, 10 to 15 years is this profound paradigm shift.
Right.
And this shift isn't accidental. It's been driven by these really radical advances in PCI. We're talking about incredibly durable, drug-eluting stents, vastly improved antithrombotic drugs, and much more sophisticated procedural techniques.
All coming together.
Exactly. These developments have basically elevated PCI to a position where it's considered comparable to CIBG for significant LMCA disease in the clinical guidelines.
So we've moved from an era where surgery was pretty much the only safe bet for survival to an era where, well, now we have a genuine choice.
It's a real choice, yeah.
And this introduces the first critical question for the clinician, doesn't it? Given the inherent risk of touching the LMCA, how do we even decide when an intervention, be it PCI or CABG, is needed at all? Because just visually assessing an intermediate narrowing, that can be incredibly misleading.
Totally misleading and dangerous if you choose wrongly.
Right.
You absolutely cannot risk operating on or intervening on a patient who doesn't actually need it. But equally, you cannot afford to miss a patient who is actively at risk of a major cardiac event because of that lesion.
Yeah.
And this realization takes us beyond just, the subjective interpretation of an angiogram, the eyeball test, and pushes us firmly into the realm of precision diagnostics.
Okay, let's talk about that critical diagnostic step then. Historically, the rule of thumb is pretty simple. You look at the angiogram, and if you saw a diameter stenosis of 50% or more, you generally move towards intervention.
That was the convention, yeah.
But the challenge now, as you said, centers on that intermediate stenosis range. Those lesions visually estimated at, say, 40% to 69% diameter narrowing.
That intermediate range is really the danger zone. Visually, a 55% lesion might look quite bad, but physiologically, it might not actually be restricting blood flow enough to cause ischemia.
Right.
Conversely, maybe a 45% lesion, but one with a really complicated plaque structure might be hemodynamically significant or on the verge of causing a problem. We need objective proof. Proof that the lesion is hemodynamically relevant, that it's actually starving the heart muscle of blood.
And the source material we're looking at highlights two primary advanced tools that provide this objective evidence. First, intravascular imaging, mainly IVUS, and second, physiological guidance, or FFR. Let's start with intravascular ultrasound, IVUS. What exactly is it, and what tangible data does it give the clinician?
Okay, so IVUS is essentially a tiny ultrasound probe that's fed through the catheter right into the coronary artery itself. It gives the clinician this amazing 360-degree cross-sectional view from inside the vessel wall.
Like looking from the inside out.
Precisely. This allows for really detailed morphological assessment. We can measure the true vessel size, we can characterize the plaque structure, is it soft, is it calcified, and most importantly, we can accurately calculate the minimal lumen area, or MLA.
MLA, okay.
Remember, angiography just shows you a 2D shadow, a silhouette. IVUS shows you the reality inside the vessel.
And this MLA measurement, this number, it gives us a clear threshold, doesn't it, for when we can potentially safely defer revascularization, which is so crucial for managing risk properly.
Yes, and that threshold is honestly one of the most important practical takeaways from this entire deep dive, I think. The established, pretty robust data supports that an IVUS measured MLA of 6 square millimeters or greater.
6 millimeters squared.
Yes, 6 millimeter each other. That's considered the safe threshold for deferring revascularization in many populations. Basically, it represents the functional minimum area required to maintain adequate blood flow down that critical pipe.
So if the area is 6 millimeters or larger, even if the angio looks a bit iffy,
the lesion is likely not hemodynamically restrictive enough to mandate an intervention right then and there. The patient can potentially be managed medically, with close follow-up, of course.
Now, the source material also mentioned a nuance here, a potentially lower threshold of 4.5 millimeters proposed in some Asian cohorts.
Yeah.
That seems like quite a significant difference.
It is significant, and it's important contextually. That 4.5 millimeter threshold was derived largely from studies focused on generally smaller statured patient populations where the native coronary vessel sizes might just be smaller overall.
Okay. Makes sense.
It doesn't necessarily invalidate the 6 millimeter rule globally, but it does emphasize that the MLA threshold is probably tied to some extent to the functional size of the patient's specific coronary anatomy.
So it's about proportionality.
Exactly. Regardless of the specific number used in a particular cohort, the underlying principle is the same. Use IVUS to get an objective non-angiographic measurement to guide your decision, defer, or treat.
Okay, that's IVUS measuring the space. Now let's pivot to fractional flow reserve, FFR. If IVUS measures anatomy, FFR measures function. Right, how does FFR guide the decision?
Yeah, FFR is purely a physiological measurement. What we do is advance a special pressure-sensing wire past the lesion, the potential blockage. Then we induce maximal blood flow, usually with a drug like adenosine. The wire measures the pressure drop across that stenosis during this maximal flow state.
And you get a ratio.
Exactly, get a ratio. The pressure distal after the lesion divided by the pressure proximal before the lesion. If that ratio is low, it signifies that the lesion is severely restricting flow and, crucially, is causing ischemia when the heart demands more blood.
And there's a clinical threshold for that, too.
Yes, the standard clinical threshold generally used to guide intervention is an FFR value of less than 0.75 or, more commonly now, 0.80.
So if the FFR is 0.80 or above, even if the angiogram looks maybe 60% blocked,
we can often, breathe a sigh of relief. It tells us definitively that the lesion is not functionally severe at that moment.
That's powerful.
It really is. And contemporary practice is very clear now on how to synthesize these tools. If a patient presents with LMCA stenosis that looks 70% or greater just on the angiogram, that's usually considered enough anatomical justification to proceed with revascularization.
The so-called severe stenosis.
Right. But for that tricky 50% to 69% intermediate group, the guidelines are firm. Either IVUS confirmation of a small MLA or FFR confirmation of functional significance, FFR, 0.80 is essentially mandatory. You need that objective evidence of ischemia or hemodynamic relevance before subjecting the patient to the risks of a major LMCA procedure.
Okay, so let's say we've used IVUS or FFR and we've confirmed revascularization is necessary. We're instantly in the territory of that great debate, PCI versus CAB for the left main.
The big one.
And for you, the learner listening, the clinical guidelines really hinge on 4 landmark randomized controlled trials, or RCTs: Syntax, Pre-Combat, Excel, and Noble.
Yeah, those are the foundational trials. And these trials, particularly the more recent ones, Excel and Noble, are where the evidence base becomes both incredibly rich, but also, frankly, quite confusing for the clinician trying to apply it.
Confusing how?
Well, they've created some real complexity in the guidelines, primarily because they reported conflicting results on their primary endpoints at 5 years.
Right. Let's walk through that core contradiction because it's central to understand the debate.
Yeah.
The Excel trial, looking at its 5-year follow-up, concluded that PCI was non-inferior to COG for their chosen composite primary endpoint.
Correct. Non-inferior.
Yet the Noble trial, also at 5 years, reported that PCI was actually inferior to CABG. How can we explain such different headline outcomes from major trials, seemingly addressing the same fundamental question?
It's a critical question, and the source material meticulously dissects the potential reasons for this discordance. It really comes down to methodology, several key differences. First, they use different composite endpoints. They weren't actually measuring the exact same combination of outcomes.
Okay, that's one factor.
Second, and this is really crucial, they had varying definitions for key clinical events within those composites, especially for myocardial infarction, or MI, heart attack.
Ah, the definition of MI. This difference is so critical and often gets lost when people just read the headlines, isn't it?
Yeah.
Can you elaborate a bit on what a periprocedural MI is and why its inclusion or how it's defined can fundamentally alter the perception of PCI versus CABG?
Absolutely. A periprocedural MI is basically a small heart attack, often detected only by sensitive blood markers, that happens immediately around the time of the procedure itself. It's often thought to be due to things like microembolization of plaque debris or maybe minor side branch occlusion during the intervention.
Sort of procedure-related injury.
Exactly. Now, when trials use a very sensitive definition for MI, including even small temporary elevations in cardiac biomarkers, PCI tends to look worse statistically. Why? Because almost any invasive coronary procedure, especially stenting, carries a measurable risk of causing some small, often clinically silent periprocedural enzyme leak. CABG also causes a form of periprocedural MI, a much larger one, typically due to surgical manipulation. But defining and capturing that consistently and sensitively across trials is actually quite difficult. The stricter, more sensitive definitions used in Noble likely captured more of these immediate procedure-related events in the PCI arm.
So it mathematically penalized the PCI group more heavily.
Correct. And this likely contributed significantly to the overall finding of inferiority for PCI in that trial. It's a massive distinction from a spontaneous MI, which is the kind that occurs weeks, months, or years later, usually due to underlying plaque rupture or stent failure, suggesting a potential lack of long-term durability in the treatment itself.
That framing makes a huge difference in how you interpret those results. So given this methodological noise in the individual trials, different endpoints, different MI definitions, researchers really had to pool the data, didn't they? What did the individual patient data, or IPD meta-analysis, which brought together data from 4,394 patients across these key trials, ultimately tell us about the most important outcome: long-term survival?
This is where we find the clearest signal, the strongest consensus. The IPD meta-analysis demonstrated that all-cause mortality was essentially comparable between PCI and CABG.
Comparable survival.
Yes. At 5 years, the difference was statistically negligible. It was around 11.2% for PCI versus 10.2% for CABG. The p-value was 0.33, no significant difference.
And does that hold up even longer term?
Well, if we look at the 10-year data, which comes from pooling the older Syntax and pre-combat trials, that trend seems to hold. Mortality was about 22.4% for PCI versus 20.4% for CABG. Again, statistically similar. So for the hardest endpoint, the one that matters most to patients' long-term survival, the two procedures appear to be largely equivalent based on the available randomized data.
Okay, so survival is equivalent, broadly speaking. But the trade-offs must be significant. Where did PCI suffer a clear disadvantage in that pooled data, highlighting perhaps the limitations of current stent technology compared to surgical grafting?
The primary difference, the main trade-off, really lies in durability or lack thereof for PCI. The IPD meta-analysis showed that PCI had substantially higher rates of needing a repeat procedure on the original treated lesion. This is known as target lesion revascularization, or a TLR.
Needing a do-over.
Essentially, yeah. TLR occurred in about 18.3% of PCI patients by 5 years versus only 10.7% in the CIBG patients.
That's a double.
It is. That almost double rate of repeat procedures is probably the clearest indictment of PCI's current limitations compared to surgery for LMCA disease. Additionally, and perhaps more concerning clinically, spontaneous MI events, those clinically relevant heart attacks occurring long after the initial procedure, were also more frequent in the PCI group. About 6.2% versus 2.6% in the CIBG group over 5 years.
So it's a pretty clear equation for the patient and the physician to discuss then. Less invasiveness up front with PCI, but you accept a higher long-term risk of potentially needing to come back for a second procedure or perhaps suffering a spontaneous MI down the road.
That's a very good summary of the core trade-off, yes.
And what about stroke risk? That's always a major concern with both procedures, particularly CBG historically.
Yeah, stroke is a devastating complication. Fortunately, the pooled data showed that stroke rates were not significantly different between the two groups over 5 years. It was around 2.7% in the PCI group versus 3.1% in the CIBG group. So the risk is definitely present with both approaches, but neither procedure showed a substantial long-term advantage in avoiding it based on this data.
The source material also points out some structural decision-making gaps, as they call them, created by how these foundational trials were designed.
Yeah.
The one that always jumps out to me, and you alluded to it, is the inclusion of repeat revascularization, TLR, in the primary composite endpoint.
Yeah, it remains a major philosophical and methodological debate in cardiology trial design. A repeat revascularization, TLR, is clearly a marker of failure of the initial treatment. You needed to fix it again. But fundamentally, is a procedure undertaken to fix the problem, not a spontaneous clinical event like death, stroke, or MI.
Right, it's a treatment choice.
Exactly. Including TLR equally alongside those hard clinical events in the primary composite endpoint almost inherently makes PCI look less favorable in the final tally, even if the ultimate survival outcomes end up being the same. This is something that really needs careful consideration in future trial designs if we want genuinely comparable data on patient-centric outcomes.
And the other point was about statistical power.
Yes, as we noted, the trials, even when pooled, were generally underpowered to detect potentially small but clinically meaningful differences in the most important hard endpoints like all-cause mortality. This is especially true when trying to look at specific high-risk subgroups like patients with very complex anatomy. And all this complexity, these trade-offs, the sometimes conflicting data, it absolutely necessitates moving beyond a simple PCI good, CIBG bad, or vice versa debate. We have to adopt a much more structured, personalized approach. And this is precisely why the guidelines now strongly mandate the use of a multidisciplinary heart team.
Okay, let's detail those guidelines more specifically. The 2021 ACA/AHA recommendations, the American guidelines, they suggest CABG gets a Class I recommendation, the strongest, or PCI gets a Class II recommendation, slightly weaker, for improving survival in patients with stable ischemic heart disease and significant LMCA disease. But there's a clear leaning towards surgery when the overall coronary disease complexity rises, isn't there?
Absolutely. If a patient presents not just with LMCA disease, but also combined high-complexity coronary artery disease, meaning extensive blockages in other vessels too, CABG is generally preferred according to the U.S. guidelines.
And the European guidelines, the 2024 ESC guidelines.
The ESC guidelines are perhaps even more granular on this point. They state that CABG is overall preferred, giving it a Class I recommendation for patients who are considered at low surgical risk.
But importantly, the ESC guidelines also give PCI a powerful, high-level recommendation, a Class 1 level of evidence, a recommendation for a very specific subset of patients. Which subset is that?
That Class I recommendation for PCI is specifically for patients with low complexity anatomy. And they explicitly define that using the syntax score, a syntax score of 22 or less.
22. Okay. Low syntax score, PCI is Class 1.
Right. Then PCI moves down to a Class II recommendation, similar to the U.S. guidelines, for patients with intermediate anatomical complexity, defined as a syntax score between 23 and 32. This really shows how central anatomical risk stratification, using tools like the syntax score, has become to the decision-making process.
You've mentioned the syntax score several times now. For a learner maybe not familiar with it, what does this score actually measure and why is it considered so crucial for stratifying anatomical risk?
Okay, so the syntax score is fundamentally an anatomical grading system. It aims to objectively quantify the complexity of a patient's entire coronary artery tree based on the angiogram.
How does it do that?
It assigns points based on various adverse features: the location of lesions, are they proximal, mid, or distal, the number of vessels involved, the presence of complete blockages, chronic total occlusions, severe calcification, visible thrombus or clot, and crucially, how many complex bifurcations or trifurcations are involved.
So it adds up all the bad features.
Essentially, yes. A low score, generally considered less than 22, implies relatively simple focal disease, which is often quite amenable to effective stenting. A high score, typically greater than 32, signifies extensive, diffuse, complex disease, or surgical revascularization with multiple durable bypass grafts is thought to be structurally and prognostically superior.
We also use surgical risk scores, don't we? The Society of Thoracic Surgeons, or STS, score is essential here too.
Absolutely. The STS score is kind of the counterpoint to the syntax score. While syntax measures the complexity of the disease, the STS score measures the risk of the patient undergoing surgery. Specifically, it predicts the patient's risk of 30-day mortality and major morbidity, like stroke, kidney failure, after CABG based on their clinical characteristics, age, comorbidities, etc.
And there are newer scores trying to combine these.
Yes, the evolving syntax 2 2020 score is an attempt to synthesize both anatomical complexity from the original syntax score and clinical risk factors like age, kidney function, ejection fraction. It aims to provide a more comprehensive risk estimation, specifically predicting long-term, like 10-year mortality, helping to guide the choice between PCI and CABG based on predicted long-term survival.
I found the caveat mentioned in the source material regarding the original syntax score in that big IKT meta-analysis quite interesting. It suggested the original syntax score wasn't actually a very powerful effect modifier for predicting differences in all-cause mortality between PCI and CABG in that specific pooled dataset.
Yeah, that's a subtle but important point. It doesn't mean the syntax score is useless, far from it. It likely means that the original trials, when pooled together, simply didn't enroll enough patients with those genuinely very high syntax scores, the patients who most clearly benefit prognostically from CBG.
So the effect was diluted.
Probably. There likely wasn't enough statistical power in that specific subgroup within the pooled analysis to definitively prove the mortality difference predicted by the score. However, expensive registry data and overwhelming expert consensus still strongly support the concept. If the coronary anatomy is highly complex, indicated by a high syntax score, CABG generally provides a clear prognostic benefit over PCI in the long run.
And this complexity, the scores, the patient factors, it all brings us back to the heart team mandate. Why is this formal discussion involving interventional cardiologists, cardiac surgeons, maybe cardiac anesthesiologists, nurses, and other allied health professionals considered mandatory now? It might seem like overkill if the guidelines and scores seem so clear sometimes.
It might seem like overkill, but it's absolutely essential because the guidelines and scores provide a vital roadmap, but they don't, and can't, capture the entire patient reality. The decision between PCI and CABG for LMCA disease is profoundly patient-centered, not just chart-centered.
What did the team add?
The heart team ensures a comprehensive 360-degree view. We discuss the anatomical risks, syntax, the surgical risks, STS, the expected impact on quality of life, the typical recovery times for each approach, and crucially, the patient's own values and preferences.
The patient's voice.
Exactly. Things like their occupation, their lifestyle, their tolerance for risk, even cultural or religious factors might influence their choice. The decision to have open heart surgery versus a less invasive stent procedure is deeply personal. The heart team structure ensures that true shared decision-making happens, informed by all the data and perspectives. Plus, allied health plays a key role in coordinating complex post-procedure care and follow-up.
Okay, let's try to crystallize the risk balance based on the source material. What specific factors tend to tip the scales decisively toward recommending CAG in that heart team discussion?
Factors that generally favor CABG are primarily related to clinical complexity and the need for durable, extensive revascularization. Key factors include the presence of diabetes, particularly insulin-dependent, as diabetic patients tend to have worse outcomes with PCI long-term and grafts may last longer. Also, significant left ventricular systolic dysfunction, a weak heart muscle, usually defined as an LVEF of 40% or less.
What else?
Extensive multi-vessel disease accompanying the LMCA lesion. Multiple, severely calcified lesions, which can be very difficult to treat effectively and durably with stents. Any contraindication to taking long-term dual antiplatelet therapy, DAPT, which is mandatory after PCI but not always after CABG depending on graft choice. And, of course, if the patient needs concomitant valve surgery or aortic surgery, then CABG makes sense to address everything at once.
Right, combine the procedures. And conversely, what shifts the balance toward favoring PCI?
PCI tends to be favored by simpler anatomy and higher patient risk for surgery. Specific factors include lesion location, particularly simple ostial at the opening, or shaft mid-segment LMCA lesions that don't involve the complex distal bifurcation. Less severe accompanying multivessel disease.
Patient factors.
Yes, strong patient preference for a faster recovery. Advanced age or significant frailty. A presentation with high clinical instability, like an acute myocardial infarction or cardiogenic shock, where getting rapid flow restoration with PCI might be safer initially than emergency surgery, and critically, the presence of high surgical comorbidities, things like severe chronic lung disease, prior chest radiation, significant peripheral vascular disease, or having had a previous sternotomy, these make CIBG much riskier, pushing the balance towards PCI even if the anatomy might otherwise favor surgery.
Now, the success of modern left main PCI isn't just about the fancy techniques used during the procedure itself. It also relies heavily on the supportive environment we've created for the patient through optimal medical therapy, or OMT, hasn't it?
Oh, absolutely. OMT is the unsung hero, the foundation upon which successful contemporary PCI really rests. We now have incredibly potent P2Y12 inhibitors, drugs like ticagrelor or prasugrel, that dramatically reduce the risk of stent thrombosis compared to older agents like clopidogrel.
And lipids.
We have intensive lipid-lowering therapies, high-intensity statins are standard, and now PCSK9 inhibitors for patients who need even lower LDL cholesterol levels. Plus, we have novel cardioprotective agents used in heart failure and diabetes, like SGLT2 inhibitors, which also seem to benefit patients with complex CAD.
How does OMT help the PCI procedure itself?
These therapies work together to dramatically stabilize high-risk plaques, reduce underlying inflammation within the coronary arteries, and lower the patient's overall acute thrombotic risk. This makes the PCI procedure itself significantly safer to perform and improves the long-term durability of the stent result. You can't really separate modern PCI success from modern OMT.
Okay, so foundation laid with OMT. Now let's look at the procedural state-of-the-art itself. We already established the importance of IVUS and FFR for diagnosis, but the source material emphasizes they are now considered pretty much essential tools during the LMCA PCI procedure as well. Why is intracoronary imaging guidance, IVUS or OCT, basically a non-negotiable component of contemporary LMCA PCI?
It really comes down to the difference between guessing and knowing, between adequacy and optimization. Angiography alone, that 2D shadow, frequently underestimates the true extent of disease and, crucially, often leads to suboptimal stent sizing and deployment.
How does imaging help?
Imaging, whether it's IVUS or OCT, gives the operator precise, real-time insights into the vessel's morphology and dimensions. It allows the operator to select the absolute perfect stent size for that specific segment of the left main. Then, critically, it confirms that the stent is fully expanded, pushing against the vessel wall properly, that's called apposition, and that an optimal final lumen area has been achieved.
And this prevents problems.
Yes, this meticulous optimization directly minimizes procedural complications like edge dissection, tearing the vessel edge, or creating geographic miss. And, perhaps even more importantly, it significantly reduces the long-term risk of stent failure due to restenosis, re-narrowing, or stent thrombosis clotting.
And this optimization isn't just expert opinion anymore, is it? It's strongly backed by major guideline bodies now.
Absolutely. This is a huge shift. The use of intracoronary imaging guidance, specifically mentioning IVUS or OCT for performing left main PCI, has been elevated to a Class I recommendation with level of evidence A in the most recent 2024 ESC guidelines.
Class I, level A, that's the strongest possible recommendation, right?
It is. It basically means you should be using it routinely for LMCA PCI based on high-quality randomized evidence.
And we have concrete proof of this benefit from specific trials mentioned in the source, like Ultimate and Renovate Complex. What specifically did they show regarding using imaging versus just relying on traditional angiography guidance for complex PCI, including left main?
The data from these trials is really quite compelling, almost practice-changing. In the Ultimate trial, when they looked at the subset of patients undergoing LMCA PCI, those who received IVUS guidance had a significantly reduced incidence of target vessel failure, a composite of death MI, or repeat revascularization, compared to those guided only by angiography.
And Renovate Complex.
Renovate Complex specifically focused on complex lesions, including LMCA disease. The results there were even more dramatic, particularly in the LM subset. Imaging-guided PCI, using either IVUS or OCT, reduced the 2-year target vessel failure rate down to about 6.8%, compared to a staggering 25.1% in the group guided by angiography alone.
Wow, from 1 in 4 failure down to less than 1 in 15.
Exactly. That magnitude of difference really demonstrates the power of precision guidance offered by intravascular imaging in these high-risk procedures. It's hard to ignore that kind of data.
But what about the relative merits of IVUS versus OCT, which is optical coherence tomography? Is one better than the other?
That's a common question. OCT uses light waves instead of sound waves, and it offers much higher image resolution than IVUS, allowing for even finer detail of stent strut apposition and tissue coverage. However, it requires clearing the blood from the field of view, usually with contrast injection, which can be a limitation. IVUS provides better tissue penetration, maybe better for assessing plaque burden behind calcium.
So, pros and cons.
Yes. The key trial comparing them head-to-head, the OCT-VUS trial, essentially demonstrated that OCT-guided PCI was non-inferior to IVUS-guided PCI for clinical outcomes. Both are highly effective tools for optimizing stent deployment. The choice between them often comes down to operator preference, specific lesion characteristics, like heavy calcium favoring IVUS, or needing fine strut detail favoring OCT, and, frankly, availability in the cath lab. The main point is, using some form of advanced intravascular imaging is vastly superior to using none.
Okay, turning back to physiological guidance again. FFR. We know its critical role in diagnosis, deciding whether to intervene, but how is it leveraged during the actual stenting strategy, particularly, say, in a provisional stenting approach at a bifurcation?
FFR plays a really smart role during the procedure, primarily to confirm the success of a simpler strategy and potentially avoid unnecessary complexity and risk. A major use case is in the distal LM bifurcation, where the LM splits into the LAD and LCX, which we'll discuss in more detail next.
How's it used there?
When the operator adopts a provisional strategy, meaning they primarily intend to stent only the main vessel, let's say, from the left main into the LAD after deploying that main vessel stent, they can immediately measure the FFR in the jailed side branch, the left circumflex artery, LCX, in this example.
Jailed meaning potentially compromised by the main stent.
Exactly. The main stent struts might cross the origin of the LCX. The FFR measurement tells you, has the flow down that side branch been significantly impaired by stenting the main vessel? If that FFR reading in the jailed LCX remains healthy, specifically a 0.80.
Then what?
Then it confirms that the side branch flow has not been significantly compromised hemodynamically.
Why is that FFR measurement so powerful in that specific situation?
Because if the FFR is preserved, 0.80, the operator can competently stop right there. They can defer performing a complex, often higher risk, additional procedure to stent the side branch, like a T-stent or culotte. An important observational study strongly supported this approach. It found that if the jailed LCX FFR was indeed 0.80 after provisional LM to LAD stenting, those patients had a significantly lower rate of 5-year target lesion failure compared to those where the FFR dropped below 0.80 and required subsequent side branch intervention.
So FFR allows you to confirm functional success and prevent unnecessary complex steps.
Precisely. It's using physiology to guide procedural strategy in real time, promoting a minimalist yet functionally adequate approach whenever possible.
Okay, we've optimized the vessel right up to the split, but now we hit what sounds like the real technical headache for left main PCI, the Y junction where the vessel divides. The source says the distal bifurcation involving the origins of both the LAD and LCX is involved in a huge proportion of cases, something like 60% to 80% of all LMCA revascularizations.
Yeah, this is really the geometric nightmare of LMPCI for the interventionalist. The single biggest immediate risk when you're working here is something called carina shift.
Carina shift.
The carina is that little wedge of tissue, like the keel of a boat, that naturally divides the flow between the left anterior descending, LAD, and the left circumflex, LCX branches, right at the end of the left main. When you inflate a stent, particularly in the main vessel, the LM extending into one branch, say the LAD, the expanding stent can mechanically push or plow that carina along with any plaque sitting on it sideways.
And that blocks the other branch.
It can acutely compromise or even completely occlude The opening the ostium of the side branch, very often the LCX, if you're primarily stenting towards the LAD. This is an immediate procedural complication that can have catastrophic consequences if not managed properly.
And this anatomical challenge, this risk of carina shift, is really what fuels that decade-long, often quite heated debate over the optimal stenting strategy here. Should we use the provisional one-stent strategy versus a more complex upfront two-stent strategy like the DK crush, culotte, or TN protrusion TAP techniques?
Exactly. The provisional one-stent strategy is essentially the minimalist philosophy. You place a stent in the main vessel, for example, LM into LAD, carefully protecting the side branch, LCX, with the wire. Then you assess the result. Only if the side branch origin looks significantly compromised angiographically, or if flow is impaired, or perhaps if FFR drops significantly, only then do you go back and deploy a second stent into that side branch, often using a T-stent or a T-tap technique.
Keep it simple if possible.
Keep it simple if possible, minimize the amount of metal implanted, minimize procedural time and risk. The two-stent strategies, on the other hand, are more like upfront surgical approaches within the vessel. Techniques like DK crush or culotte aim to guarantee complete metallic coverage of both branches and the carina itself right from the start. But they come at the cost of much higher procedural complexity, more hardware, longer procedure times, and potentially higher risks if not executed perfectly.
And wouldn't you know it, here again, we have conflicting trial data creating clinical friction and debate. The source highlights DKCRUSHV, which was predominantly an Asian cohort study. What did it show?
DKCRUSHV showed that the specific two-stent technique called double kissing crush, DK crush, was actually superior to provisional stenting for complex distal LM bifurcations. They reported significantly lower rates of target lesion failure, TLF, at both 1 year and 3 years in the DK crush group.
Okay, so DK crush wins in that trial.
Yes, but then you have the large European EBC Main trial. EBC Main compared a strategy of planned provisional stenting against a strategy of planned upfront two-stenting, using various techniques like culotte or T-stenting, not exclusively DK crush, for distal LM disease. And that trial reported essential equivalence between the two overall strategies at 5 years, no significant difference in the primary composite endpoint.
So one trial says two-stent DK crush is better, another says provisional is equivalent to two stents. How do we reconcile this?
Again, it likely comes down to nuances in patient selection, endpoint definitions, and perhaps most importantly, the specific techniques used and operator expertise. DK crush, in particular, is an incredibly technique-dependent procedure.
Can you briefly describe it? It sounds complex.
It is. It involves carefully positioning and deploying a stent in the side branch first, allowing it to protrude slightly back into the main vessel. Then you inflate a balloon in the main vessel to crush that protruding side branch stent against the wall. Then you rewire the side branch through the crushed stent struts, perform an initial kissing balloon inflation with balloons in both branches simultaneously. Then you deploy the main vessel stent. Then you again rewire the side branch and perform a final kissing balloon inflation.
Wow, that's a lot of precise steps.
It's a multi-step, highly complex procedure requiring real surgical precision inside the artery. If it's done perfectly by experienced operators on the right patients, it might indeed provide a superior anatomical and clinical result, as perhaps reflected in the DK-CRSH-HAV trial outcomes. But if any of those steps are done imperfectly, it can lead to major complications like stent deformation, incomplete expansion, or difficulty reaccessing branches. This might explain why EBC Main, which involved a broader range of European operators using various two-stent techniques, found overall equivalence the potential benefit of two stents might have been diluted by suboptimal execution in some cases.
So given all that complexity and the conflicting data, what is the current general consensus for the average skilled interventionalist today, leaning on the totality of evidence and guidelines?
The current consensus, reflected in recent guidelines, is still generally to favor the provisional one-stent technique as the default strategy for most distal LM bifurcation lesions.
Default to provisional.
Yes. You aim to minimize the amount of metal implanted, keep the procedure simpler and likely safer in most hands, and you only escalate to a second stent if clearly necessary based on the result in the side branch. However, and this is a crucial however, an upfront two-stent technique, particularly the DK crush technique, given its strong performance in dedicated hands and trials, is recommended for lesions that are deemed truly complex right from the outset.
Can you define truly complex in this context based on the source material? What are the specific features that should push an operator towards planning an upfront two-stent approach?
Yes, the source material and guidelines generally define these complex features based on the side branch, usually the LCX. An upfront two-stent strategy, like DK crush, should be strongly considered if the side branch stenosis is already severe, say 70% diameter stenosis before you even start the procedure, or if the lesion in the side branch is long, typically defined as 10 millimeters in length. Other factors favoring an upfront two-stent approach include severely calcified anatomy involving the bifurcation, which makes post-stent optimization difficult, or if there's anticipated difficulty in accessing or wiring the side pouch after the main vessel stent has been placed. Basically, if you foresee a high likelihood that the provisional approach will fail to give a good result in the side branch, it's often better to plan for and execute a meticulous two-stent strategy from the beginning.
Okay, that clarifies the bifurcation. But what about moving from the wide junction bifurcation to a situation where the left main actually splits into three significant branches, the LAD, the LCX, and a large intermediate branch? This distal trifurcation must be exponentially more challenging to handle with PCI.
It absolutely is, though thankfully it affects a smaller subset of patients, maybe around 10% to 15% of those with distal LMCA disease. The source material explicitly notes that reliable, evidence-based PCI solutions for true trifurcation lesions are significantly limited.
Why so difficult?
Well, all the problems of bifurcation, carina shift, side branch compromise, ensuring full stent coverage are magnified. You now have two potential side branches to worry about. Current data, which is mostly observational, not from large RCTs, suggests that attempting to deploy multi-stent techniques to cover all three branches often results in higher rates of target lesion revascularization, TLR, down the line. It's simply because the total metal burden becomes very high, the geometry is incredibly complex, and the risk of suboptimal stent deployment somewhere in that three-way junction increases substantially.
If we use kissing balloon inflation to optimize the result in two branches, LAD-LCX, after stenting, is there a logical extension of that concept for three branches?
There is, conceptually at least. The source mentions the potential role of trissing, or triple kissing balloon inflation. This would involve using balloon inflation, perhaps sequentially or even simultaneously if anatomy allows, in all three major branches, LAD, LCX, and the intermediate branch after the main stenting procedure, in an attempt to optimize the final stent expansion and apposition at all three ostia.
Is this commonly done?
It's a highly specialized, technically demanding maneuver, and critically, we completely lack large-scale randomized trial data to provide robust, evidence-based guidelines on the best PCI strategy for LM trifurcation disease, or even to prove that trissing is beneficial or safe compared to simpler approaches. It remains a real area of uncertainty and technical challenge. So despite all these really quite stunning technological leaps and refinements in technique, the story of left main PCI is clearly far from finished. We still struggle with significant knowledge gaps and unmet needs, especially surrounding what actually happens long-term when the procedure fails, when restenosis occurs in this critical location.
Yeah, the prognostic impact of needing that repeat procedure, TLR, seems fundamentally confused or at least debated based on the available data. For example, the source mentions that one analysis from the Excel trial actually suggested that needing TLR after LMCA intervention was associated with higher subsequent mortality.
Right, which is worrying. And yet, a more recent, larger pooled analysis, which followed patients for nearly 7 years, seemed to find the exact opposite. In their data, TLR was not independently associated with an increase in all-cause mortality over 10 years.
That conflict is jarring. How can we possibly reconcile those findings?
It's difficult. One potential explanation, which the source material touches upon, is that failure of an LMCA intervention might manifest differently than failure elsewhere. For critical LMCA lesion, significant restenosis might not always present with symptoms leading to another planned revascularization procedure, TLR. It might tragically present as sudden cardiac death.
So TLR rates might underestimate the true risk.
Exactly. If LM restenosis sometimes leads directly to death before TLR can occur, then studies focusing solely on TLR as the failure endpoint might be underestimating the true long-term prognostic impact of stent failure in this location. We do know, however, from the data that the incidence of TLR after LMPCI is highest within the first year or two post-procedure. So the durability question seems particularly concentrated in that early phase.
Okay, let's pivot then towards the future. The source material does a great job outlining several key ongoing clinical trials that are specifically designed to resolve some of these critical gaps and will likely define the guidelines for the next decade. First, Where are we with getting better diagnostic guidance for those tricky intermediate LMCA lesions?
The FATE main trial is probably one of the most anticipated trials in this space right now. It's an ongoing randomized controlled trial designed to directly compare FFR-guided PCI versus traditional angiography-guided PCI, specifically for patients with unprotected LMCA disease, focusing on those intermediate lesions.
What do we hope to learn?
This RCT should provide the definitive level A evidence on exactly how we should manage that challenging 50% to 69% intermediate stenosis range using physiology. Should FFR guide the decision to intervene or defer? This trial aims to answer that head-on.
And regarding the crucial question of long-term durability, we really need follow-up data beyond the standard 5-year marks of XL and Noble, don't we?
Absolutely. Extended follow-up, ideally out to 10 years and perhaps even beyond, for both the Excel and Noble trial cohorts is critically important. Many of the patients enrolled in these landmark trials were relatively young and otherwise reasonably healthy at baseline. We really need to assess whether that observed higher rate of TLR with PCI in the first 5 years eventually translates into a later survival disadvantage compared to the known long-term durability of surgical bypass grafts, especially as patients age and develop more comorbidities.
We also discussed the strong recommendation for using imaging guidance, IVUS-ET, during LMPCI, but you mentioned it's largely based on pooled data or subset analyses. Are there dedicated focused RCTs underway to confirm this benefit specifically in the LMCA population?
Yes, thankfully those trials are finally ongoing now. The source mentions two key ones: the optimal trial, which stands for optimization of left main PCI with IVUS, and the infinite trial, focusing on IVUS versus angiography-guided PCI specifically for LM bifurcation lesions.
What's their goal?
These are dedicated RCTs specifically designed to prospectively confirm the profound clinical benefit of using IVUS or OCT guidance compared to angiography alone during complex LM-PCI. Positive results from these trials will solidify that Class I recommendation with even stronger, more direct evidence tailored to the LM population.
Now, a hugely important and particularly vulnerable subgroup is patients who have both significant LMCA disease and poor left ventricular function, basically. Weak heart muscle, often termed ischemic cardiomyopathy. Historically, these patients almost always went for surgery. What trials are addressing this specific high-risk population now?
That's the crucial question being addressed by the STS-CH3C trial. This trial is actively recruiting patients who have known ischemic cardiomyopathy, defined by a left ventricular ejection fraction, LVEF, of 40% or less, and significant LMCA and/or multivessel coronary artery disease suitable for either PCI or CABG.
And it's randomizing them.
Yes, it's randomizing them to receive either contemporary PCI with all the modern techniques we've discussed, or CABG, and it will compare long-term outcomes. This population has historically defaulted to surgery based on older data, but STK-ACE3C will give us much-needed contemporary randomized evidence to better guide risk stratification and treatment choices in these very high-risk individuals.
I found the recharge trials, mentioned in the source, fascinating because they seem to be addressing two key gaps simultaneously: improving diversity in trial populations and also using a broader, more patient-centered definition of success than just survival or freedom from MI.
Yes, the Recharge program is a really important step forward, I think. It includes separate, dedicated, randomized cohorts specifically for women and for underrepresented minority populations, groups often poorly represented in past cardiology trials.
And the outcome measure is different.
Crucially, yes. These trials aim to compare PCI versus CABG in these specific populations, but they're using overall quality of life combined with mortality as the primary composite outcome measure. This explicitly moves the goalposts beyond just technical success or avoiding heart events and focuses much more on the patient's functional status, symptoms, and overall experience after the intervention. This kind of data is absolutely vital for truly informed, shared decision-making.
Finally, the source points out what seems like a major, perhaps surprising, evidence gap when it comes to comparing modern revascularization, either PCI or CABG, against truly contemporary optimal medical therapy, OMT, especially for less severe LMCA stenosis.
This really is a massive blind spot in our current evidence base. Much of the survival advantage we assume for revascularization in LMCA disease today is actually based on extrapolation from trials conducted way back in the 1980s and 1990s. That was long before the advent of modern potent statins, potent P2Y12 inhibitors, PCSK9 inhibitors, SGLT2 inhibitors, and modern heart failure agents.
OMT is much better now.
Dramatically better. So while we strongly believe, and guidelines reflect, that revascularization is beneficial for severe LMCA stenosis, say 70%, the situation is much less clear for intermediate LMCA stenosis. maybe a 50%, 70%, in patients with preserved heart function and no major objective evidence of ischemia, for example, negative FFR or IVUS.
We lack the head-to-head trial.
We completely lag a large-scale, high-quality, modern RCT that directly compares intervention, PCI or CABG, against state-of-the-art, guideline-directed medical management alone for that specific intermediate LMCA population. Right now, the decision to intervene or manage medically in those cases is often still based largely on inference, extrapolation from older data, or expert opinion, rather than direct contemporary comparative evidence. That's a gap we urgently need to fill. Hashtag tag outro.
Okay, let's try to synthesize all of this remarkable progress and complexity. I think the overall conclusion from this deep dive is that remarkable advances in PCI technology, the stents, the imaging, the adjunctive tools, along with sophisticated procedural finesse and vastly improved optimal medical therapy, have significantly expanded the treatment options for patients with left main coronary artery disease.
Absolutely. For many patients now, particularly those perhaps with lower anatomical complexity as defined by the syntax score, or those who pose a high risk for surgery due to comorbidities, PCI has emerged as a fully comparable, safe, and viable revascularization option alongside the traditional standard of CIBG.
But the journey through the evidence has really shown us that both the diagnosis and the optimal management of LMCA disease require extreme precision and careful consideration. We've clearly moved beyond just subjective angiographic assessment, with guidelines now mandating the use of advanced tools like IVUS and FFR for both confirming the need for intervention and, critically, for optimizing the procedural result if PCI is chosen.
And that core challenge, that central trade-off, remains. CABG generally offers better long-term durability, particularly regarding the need for repeat procedures, but it comes with higher upfront invasiveness and recovery time. PCI offers that less invasive approach, but carries a higher known rate of needing target lesion revascularization, TLR, down the line, and perhaps a slightly higher risk of late spontaneous MI, although overall survival appears comparable.
And what really stands out to me as the ultimate practical takeaway is how the guidelines are now explicitly demanding a truly patient-centric approach. That absolute necessity of the multidisciplinary heart team to navigate these complex risk scores, the sometimes conflicting trial data, and most importantly, to ensure the individual patient's context, values, and preferences are placed right at the center of the decision-making process.
Well said. And perhaps that leaves us with a provocative final thought for you, the listener, to consider, linking back directly to that identified gap in the OMT research. If you have a patient presenting with, say, truly intermediate LMCA stenosis, let's imagine a 60% narrowing on angio, but they have preserved heart function, and crucially, no significant documented ischemia as confirmed by a negative FFR or a large MLA on IVUS. Should we still be aggressively pushing for revascularization in every single one of those cases?
Or is there another path?
Or is careful, diligent, long-term follow-up combined with truly maximized, modern, powerful preventative medical management sometimes the optimal and perhaps even the safest path for that specific patient? Answering that particular question, defining the precise role of contemporary OMT versus intervention for non-ischemic intermediate LMCA disease, that may well define the next major evolution in how we manage this critical condition.
A crucial balance indeed for the medical community to continue to explore and define. This has been a fascinating deep dive into the contemporary state-of-the-art treatment for left main coronary artery disease.
Thank you for watching The Funnel Effect.